I would like to introduce our next speaker, Dr. Jessica Schwartz. She's a doctor of physical therapy, founder of Concussion Corner Academy, and also host of the Concussion Corner podcast. Today, she will share her personal journey, insights, and long-term concussion symptoms with us. And let's give a warm welcome to Jessica. Thank you for having me here.
Thank you. I have my emotional support water bottle here, so let's see how this keeps here. Put this down. Okay. All right. Well, thank you so much for having me. I came a long way. I came from New York, so from a small town called New York City. So it's really an honor and a privilege. This is all that I want to do in my life, is speak to healthcare professionals all over the world and basically amplify and empower that concussions are rehabilitative and you actually have the power to help so many people. So I live by the motto of teach one, serve many, and I hope I impart that on you today. So again, thank you for the sports physio community for inviting me out here. I learned so much just from dinner and conversations today, and we're going out again tonight. But I think what this really is here for, also thank you for Dr. Bazzini for having me. But I think this is here is that we're all kind of talking about the same thing, except for I'm here to talk about kind of central command, how this all kind of drives the system. And what you are going to find is that there's going to be interweaving of all of our talks today in this talk because it's all one person, one body. So how many people identify as orthopedic physio? Orthopedics? Musculoskeletal? Neurologist? Neurology physio? Neurophysio? Okay. Sports physio? Okay. I know where I'm at, know the audience. So again, this is going to traverse all of those areas. So again, I think it's just important to connect to when Dr. Bazzini reached out to me and he, this is my life's work, and he's like, can you deliver this talk in 20 minutes? And I was like, good Lord. So what was one of the conversation talking points, so we call it a little behind the scenes, is he said, we really feel that we're behind from America on the topic of concussion. Well, I'm from a small island called New York City, called Manhattan in America, and we have 8 million people on my island overnight that we sleep and we live there, and we have about 16 million people there in the day that come visit or work. And that we double in size. And I know that Switzerland also has about 8 million people here in this country. The good news is, I actually spoke in Wyoming, and they actually had more cows than people there. So you're ahead of Wyoming, I can say, in terms of you're feeling a little unsure about the topic. But the good news is that we have the same conversations all over the world, no matter what your population. There's much more of a mismanagement of a concussion patient than the well-cared-for concussion patient. And I truly believe in that today. And it's not from anything from a nefarious point of view. It's just that it's very Dunning-Kruger-esque. You don't know what you don't know. So I hope to amplify this topic of concussions are rehabilitative, and we're going to focus on believing your patient today, and then I'll be providing you, so everyone has anxiety about taking notes, with a handout that will actually help you after, so you can keep learning after this talk. So this is our topic today, believing your patients, okay? The medical legal world overtook this world of closed head injury, MTBI, and concussion. And really, it's not until the last 10, 15, maybe 20 years that we've started to work in this field in terms of having the conversation that this is a rehabilitative injury, okay? And we'll talk about that today. The number one thing that people ask me, and I think this is one of the most important talking points of my career, is that you need to validate your patient's symptom profile. The reason being is because on average, when people see me in New York City for my practice for concussion consultations, they see on average 8 to 10 providers before they see me. Now, my job is to lift healthcare professionals up from an interdisciplinary standpoint. I need to reach across that aisle and have that conversation. However, it doesn't mean that they were a bad clinician. It just means they were not trained in concussion. And we're going to talk about that today. To feel with stirs us to act for. And again, we have a lot of patients that make the news all over the world, from Scotland to Canada, in rugby, in Washington State, in the US, that have passed away from second impact syndrome. I'm here today to talk about persistent post-concussive symptoms and what it is to live with that, and how it is to treat that for the healthcare provider. The key here is that this is rehabilitative, and we see patients from the military to post-car accident, intimate partner violence, post-port concussion, 5, 10 years out, and we can still rehabilitate them from those concussion symptoms. So we have to think about the brain as being plastic, and we're going to talk about that. Concussion is a clinical diagnosis only, and no matter what you see on the news, you have to remember that, and we have to advocate for that as clinicians. And I know it's after lunch, everybody, so please, if you need to stand, take pictures, whatever it is to keep it engaged, absolutely. So concussion is a clinical diagnosis only if you take anything from this lecture. This is how you're going to advocate for your communities, okay? You as physio need to advocate that, and we need to take the lead here. Okay, we need to make sure that we're looking at the patient's 360, and all of that we just learned from Dr. Gard and Dr. Kvist and Dr. Groom from earlier today. We have to be able to implement all of that, and it's all related. You already have the vernacular, you already have the skill set to think in short and long-term goals, and then you can actually implement that into function. So it takes a village. I won't go through the whole, but again, we want to make sure that we're really honing in on the interdisciplinary component of concussion care. It's not a ego situation it used to be. We want to make sure that we're reaching across the aisle, we're working with our colleagues, but we're also taking the lead and talking about function rehabilitation. I'm sorry, I think that was a double slide. So the most commonly prescribed intervention for concussion is actually physical therapy. Okay, it's followed by speech therapy, neuropsychology, and occupational therapy. Most people aren't aware of that because the neuropsychology field have actually taken over with a lot of software, but PT is the #1 most prescribed. So again, this is empowering, and I would love to see that number quadruple or triple in the next couple years. One of the biggest things that I see wherever I go all over the world to speak about concussion is, hey, Jess, I had this concussion patient, it was like a whiplash patient, or they fell, they hit the ground in football, and I treated their neck and they got like 80% there. And that's like the most common thing that you'll see all over the world, is, well, I did some exercise therapy with them, and I just can't figure out what that last little bit is. It's usually gonna be the visuovestibular system, okay? Unless there's like a neuroendocrine component to it as well. So just to keep in mind, smooth pursuit is a nice, slow movement of the eyes, and saccades is what you're doing right now, is you're reading the slides. It's a quick, rapid eye movement, okay? Look how much the brain opens up and lights up with saccades. What's going to happen to you is going to be something that usually causes fear in the healthcare professional. You flare your patient up in the clinic from a seemingly benign intervention. Usually it's ocular motor, potentially vestibular, or both, but it's seemingly benign. You have to remember that 2/3 of the brain's pathways are devoted to vision. 70% of your sensory environment comes through your eyeballs. So if we're thinking from a plasticity standpoint, muddy in is muddy out. So how in which you're processing the environment is key. And attention is our most valuable resource. And if you're auditorily impaired as well, which often happens, you can see how this goes. So seeing is a way of unseeing. So if you identified as an orthopedic physio, a musculoskeletal physio, a neurophysio, I challenge you to kind of cross over the aisle and open up that vernacular across the aisle. If you specialize in the cervical spine, those CO to C3 afferents, absolutely. Open up in the neuro textbook, open up the conversations across the aisle with your neuro colleagues. So I created this, this cartoon. Oh gosh, I think in 2015, there was a cover of the British Journal of Sports Medicine. I don't know if you remember, Mario, but there was a cover of blindfolded physicians that were touching an elephant. And they're like, oh no, this is a rope, and it was the tail, and oh no, this is a sheet, this is a wall. So I kind of extrapolated that and put this into the brain. But this is still very much true today. Everyone's kind of ownership, that collective competence versus individual competence. You cannot be individually competent and treat concussion. You have to have collective competence to treat concussion and reach across the aisle. And so that's, if you connect with anything but that, you're going to probably be the top 1% of what you do for your field. But again, if you're not looking at that patient 360, is there a feedback? I hear feedback, okay. If you're not looking at that patient 360, I think it was I hear. If you're not looking at the patient 360, you can't do them justice. So we're going to take a humble approach today, and we're going to talk about perceived competence. In this, it's very much like an armchair expert. Oh, I watch hockey, I watch football, I watch basketball, I watch ESPN if you're in the States, and people have this perceived competence about concussion. Well, again, can you imagine being, God forbid, diagnosed with cancer and walking into an office for like an oncologist and them just being like, well, we're going to rest a little bit. Well, that's what we did. In absence of evidence in healthcare, we tell people to rest. We've seen it in pregnancy, we've seen it in multiple sclerosis, we've seen it in other areas as well. In fact, though, that actually does harm. We do harm when we tell people to not move, and we heard a little bit about that earlier with even just developmentally with children having to move to think to learn. So that's something that you'll come into, which is very unusual for the field. Not a lot of people are going to come in and tell you how to take care of that ACL or that shoulder, but the perceived competence of folks with concussion is very high. This is for you, just to kind of give you some really solid resources. I say that concussion is a complex injury. It is defined as a traumatic brain injury, okay? However, complex does not have to be complicated. Where complicated happens is when the patient is mismanaged, okay? And how can you, with this new knowledge that you're gonna get, how can you mitigate that in your care for your community? And again, this is just a fantastic image from that article, just kind of showing the experiential, the network, the personal. Is there litigation involved? And then another shout out to Dr. Becky Bliss out in the US, also just posted this a few months ago, Experienced Clinical Decision-Making in PT of Concussion, and it was a qualitative study, and essentially looking about how experienced clinicians in concussion think, and it's a fantastic paper to read. I highly recommend it. I think it was a JOSPT article. So in order for us to get through being able to advocate for our patients, we have to kind of think about the historical nature of it. And the key to successful and positive outcomes is understanding the historical nature of the injury, again, because it's so polarizing to so many. So historical landmarks for the concussive injury. Just gonna take a sip of water. Are as follows. I'm an American physio, so I'm one of our national spokeswomen for the American Physical Therapy Association. So it's super prideful for us because we just turned 100 years old in 2021. The physical therapy is 100 years old, and ironically, we started during a pandemic. Okay, we all made it through. So we started there. I bring that to your attention because we started that during World War I. Okay, and I'm very aware of where I am. And we started that literally in the trenches, treating traumatic brain injury. We were rehabilitation aides back then, and we were literally treating traumatic brain injury. We didn't tell these soldiers to go rest. We got them up, we got them moving. If you're in the ICU, what do? You have the Foley bag, you've got all the IVs, you're getting them up and going. But with concussion, we told people to rest. And again, that's a do harm. We want to make sure that we're doing no harm for our patients. Sorry, let me go back. I'll actually take you through. So we have the formation. This is going to be like a New York minute, so it'll be quick. I bring this to your attention because the American College of Rehabilitation Medicine formed this task force in 1993. Okay, we're going to come back to this for 2023, but just think about that in terms of where we are. The 7 to 10 day paper is the most popular paper, I believe, in concussion. And it is where we do harm to patients now if we haven't updated the literature. It takes 8 to 17 years for knowledge translation to happen from white paper to clinical practice, okay? These guys, Steve Brolio et al., have written new papers that debunk this, and we'll talk about that. But we don't want to be doing anything time-based. Again, when we do a musculoskeletal injury, when we're rehabbing that, 6 to 8 weeks for normal tissue recovery, that's kind of, you can predict that. With brain injury, not so much. So you have to know what you're looking at so you know what you're looking for. So they didn't do anything nefarious on purpose back in 2002 or 2003. However, we now know better, so therefore we do better. And again, you have to know what you're looking at so you know what you're looking for. Concussion G-forces take about 70 to 120 Gs. Whiplash-associated disorder, 4.5 Gs, very low. However, the crossover with concomitant signs and symptoms are very high. This was my concussion education in 2006 in New York City. Okay, it was one paragraph in like a 1,500-page neurological notebook. Okay, so again, we're all still ground floor, ground level. We stopped grading concussion in 2008, so stop it. I'll come after you online. I'll say, no, you don't do that. You learned this. I saw you. We don't grade concussion anymore. Okay, we don't say it's a mild or severe concussion. In fact, that does harm to the patient because you're going to set them up for being prepared for a mild concussion, and then 2, 3, 4 weeks later, and they're still feeling sick. That's going to cause psychological trauma to them because they're going to be ruminating on why aren't they better. Fastest thing that was ever passed in America, reached across all 50 states, and it was the Zach Gleistedt law. I'll just keep it moving for the interest of time. We started the world's first prospective study during the Obama administration, and in 2014, Brian Hainline et al. Went over to the White House and got NIH funding. So it's the world's first prospective study, and that's important because we now know so much information from this. Specifically, we didn't have concussion studies with controls. So in America, what we're doing now is we have cadets and service members and NCAA athletes, Division 1, 2, and 3, and they're kind of all put in this pool, and you'll see we have over 53,000 student athletes participating and cadets, over 100 different sports and activities, and close to 6,000 concussions now have been documented in about a decade. So all of that data will be extrapolated with blood work and MRIs and so on and so forth. So we're getting there. The updated data from the 7 to 10 day paper, though, however, is it takes about 1 month for the majority, about 80% of participants. Now you have to remember, these are athletes, these are cadets, these are servicemen and women. So that these are like the upper echelon of people who are fit. So now think of your normal community members and how things may take longer even from that. So just keep in mind, you have to pay attention to where you're meeting your patient. 2012 was the first year we talked about the cervical spine and concussion. That whole portion of that makes that stick that holds the head to the rest of the body, so that CNS to the ANS to the PNS, and it's the first time that we talked about the cervical spine. 2015 was the first formal didactic year that neurologists and physicians, brain physicians in America had training in concussion. I was hit by a car in 2013. So we have, again, a high prevalence of mismanagement of people being told to rest and wait and see, okay? And how does that cause harm? And that's very recent and still happening to this day. Concussions are rehabilitative, we got that, and we've come full circle. We do have a clinical prediction guideline for you now. In 2020, it was published. It was a bit behind, if I'm honest, when it was published. We're just gonna be very honest with it, but it's still ahead of the game, and we're hoping to have that in a living guideline in the next few years. An excellent free resource for you. Fast forward to that first slide that you saw. 30 years later, they just republished a MTBI concussion definition with a new consensus published. We could not agree between the BJSM definition and the ACRM definition, and that just goes to show you how we're still learning about TBI and concussion. If you do anything after this conference, after you take a nap or go have a beverage, this is a great place to spend your time. The TBI classification workshop, Rethinking TBI Classification for Clinical Care and Research, happened in January in Bethesda at NIH, which is where we get all of our funding for everything healthcare and research in America. And it was phenomenal. It's free open access. It's about 4 or 6 hours of content, but it's really fantastic. What you'll find there are these topics that I'm just going to kind of move through because I want to get through this next slide. And what they talk about is proposing new time points, okay? And you're going to look at acute, subacute, and chronic post-injury, which is why I'm here today. And they're looking at chronic from everywhere between greater than 1 month, so 1 to 3 months. So the classification component of that comes, well, what is mild, what is moderate for traumatic brain injury, and the perception of biases. So what does that mean? Time post-injury, day 1, day 14, day 365. We want to make sure that we're looking at serial evaluations for concussion and that we're following up with them. Athletic trainers are phenomenal, people that we can utilize in the US for that. And just as of June 2024, this summer, coming up for January 2025, this is one of the most important things you'll learn, especially if you're practicing in America. It's an important first step. We're defining traumatic brain injury, so TBI, as a chronic health condition. Think about that for a second. Traumatic brain injury is going to be classified with cancer, with end-stage renal failure, with HIV, with age, with major psychiatric issues, anything chronic health. Okay, there's 21 chronic health conditions that we identify for the Center of Medicaid and Medicaid Services, and TBI is now going to be the 22nd. Okay. Mild traumatic brain injury is a word that describes traumatic experiences with untreated symptoms and endured for months and years. MTBI is a term that promotes denial about the symptoms that the majority endure of a severely long period with big challenges and bad consequences. This is someone who was a severe traumatic brain injury survivor of a Glasgow coma of 3. Doesn't get lower than that. So he was in a coma in the ICU. He educates folks on MTBI and concussion, and this was brought up at this conference. Lindsay Simpson is a former professional athlete and sports broadcaster. She was hit by a beam in a soccer stadium while she was working, and she said the misnaming of mild classification was weaponized against me. Okay, it was used to malalign my character. People didn't believe her. She didn't have access to rehabilitative care, and she was going through litigation, so it actually impeded her injury recovery. And then we're here now in 2024. So what do we do with these patients? These patients, I hear all the time. So let's just take a breath because there's a New York City minute. All right. What do we do with these patients? So we have to understand the definition of concussion. However, what I can tell you is there are over 43 working definitions of concussion, and we're not going to talk about them today. What we are going to talk about, to keep it simple, because we need to keep it simple for our community and other healthcare professionals, is that it's a bump, bolt, or blow to the head or body. You do not have to hit your head to have a concussion, okay? If you ever fell off that bar stool and right on your bum and kind of that force reverberated off and you felt a little off, we can qualify that as a concussion for today's talk. Simplicity is the key when you're speaking to the public. So 20 years ago, to the right, my anatomy lecture looked like this. I was coloring in the occipital lobe in the posterior aspect of the brain, and we've totally adapted, okay? 2/3 of your brain's pathway are devoted to vision. I will say that over and over and over again. Vision is really going to be the key to help rehabilitating these folks, because this is the number one thing that's missed overall. So keeping in context with the TBI being a chronic health condition coming up in January and being identified as that, we've known it for years in the rehab field. It's not an event, it's not a moment in time, it's a process. Okay, and just think about that. Keep that in your mind. You want to make sure you know where you meet the patient. Are they 1 day out, 2 days out, 2 weeks, 3 years out? And again, we want to validate that patient symptom profile. The difference between all of the other folks that have presented their context today is that we have a cognitive and a behavioral. Cognitive and behavioral impairments differentiate concussion from other musculoskeletal injuries and brain injury. As a survivor, when I went back to work after residency, I was unable to tolerate my environment. We went totally green. We owned our clinic. We were written up in the newspaper, a green physical therapy clinic in New Jersey. I couldn't tolerate the lights. I had horrible referred pain, eyeball pain, and I couldn't tolerate my environment. So we have to add the environment as well. Okay, can they dual task? Can they process? So you're going to think outside of the box. You've learned so much so far from all of these wonderful humans that you've learned from, and you're going to continue to today. But how can you implement your rehabilitation plan for the concussion patient? So persistent post-concussive symptoms, again, the title kind of the lecture, I just want to be really clear, because when we're trying to phase out the word syndrome. Syndrome literally leaves people feeling helpless, and it has no end in sight. So we're trying to shift over to persistent post-concussive symptom, okay, PPCS. So that's just a kind of little inside tidbit there. Predictors of persistent post-concussive symptoms are as follows. Receded near point of convergence, NPC, near point of convergence, vision. Symptom provocation on vestibular ocular motor testing, vestibular vision. Dizziness, premorbid anxiety or depression, 3 or more of the previous concussions. Higher prevalence of vestibular deficits took longer to recover. So again, we can do that by doing comprehensive targeted physical examinations and validating the patient's symptom profile, and therefore you can design the interventional programming or referral. So functional outcomes in people, I'm just going to go through this briefly, but it's important to connect to because we learned a lot about the biological aspect, which happened in rats. But you can see here the ionic flux leads to migraine, headache, and photophobia. 94% of folks will have migraine or headache after concussion. Okay? There's an energy crisis, so you're vulnerable to a second injury. The axonal injury, which we cannot see on any imaging quite yet, impaired cognition, slowed processing, and slowed reaction time. We see gait initiation delay after concussion. Okay? That's why we see up to 80% of lower extremity injuries within a year of concussion. So what does recover mean? Okay. And we'll keep going. So what we see kind of behavioral components like we saw from the prior slide, cognitive behavioral. Attention is our most valuable resource. We cannot process. We have about 120 hertz of processing speed, which was my computer in 1998. And if I was talking with Suzanne here, or Suzanne there, Suzanne here, it would take 60 hertz of processing. So therefore, I can hear Dusty talk to Mario and still kind of have an idea of what's going on, but still attend to Dr. Gard. Okay, that all goes out the window with concussion. And that is seen behaviorally. So I want you to connect to concussion is an injury of loss. So when you're prescribing or removing things from someone's life, especially sport, we have to make sure as physios we give something back. If we're removing sport, they have to go to practice. They have to walk the track. They have to be with the team. They can't be isolated. It's a loss of your I am. I am funny, I am wife, I am physio, I am doctor, so on. And I knew my space, so ich bin, je suis, and so on. Neurons are living cells with a metabolism. When we have that injury, we see fatigue. It's common in there. I'm just gonna stop it there for time purposes. But imagine throwing salt water on your cell phone and seeing how it functions. If you put it in a scanner, it's going to scan the same. We don't have that technology to see the axonal breakdown. So you're gonna see that in your comprehensive and targeted physical exam. I'm just gonna move along so we finish on time. So we do that by doing comprehensive and targeted physical exams. The key thing here that I'm going to leave you with today is we do not do symptom-driven diagnosis, asking people how they feel. We do not have the subjective language to express the what and how we feel with a brain injury. Okay, I'm going to say it twice because it's so important. We don't have the subjective language to express the what and how we feel with a brain injury. So we have to make sure all we do all day is how do you feel, how do you feel, how do you feel, and take a number down. So be mindful of that with your patients because, again, there can be some concomitant crossover, which we saw with whiplash earlier. What I will leave you with, which you'll have in a handout with Dr. Bazzini, and I'll give that to him after conference, is you're going to learn about the concussion clinical trajectories, okay? And you're going to learn about how that's rehabilitative. I'm going to leave you with a concussion toolbox, okay? Something that, for the interest of this time period of the 20-minute lecture, this is what I think is best for you to start, okay? You're going to have the concussion clinical profile screening tool. This you will actually verbally go through it with your patients because, again, you don't want them using saccades and reading for when they come through. It's a tool that looks like this. And this is what we designed at our school. But essentially, you'll grade that and take the average. And it's been validated 3 months ago. The BJSM International Consensus Statement is there for you. The SCOAT itself takes 30 minutes. There are other options out there, but this is a good place to start. The Human Movement System is our professional identity, so therefore we have to make sure that we're moving our patients. The new guidelines are saying that the first 3 components are therapeutic, so we want to make sure that we're exercising and using objective measures like a heart rate monitor to get folks back and get them moving. We recommend the Buffalo Concussion Treadmill test for you. If you don't have a treadmill, they have a bike test. If you don't have a bike or a treadmill, there is a march test. So by all means, this is something that you can do. This is both physiological identification and also rehabilitative and probably prognostic at some point in future research. So we believe your patients, you're going to build therapeutic alliance by doing that. You're going to validate their patient symptom profile, and you're going to cultivate the clinical hours and mentorship to do so. Reflecting on my journey of courage, struggle, and kindness, I went through 10 to 14 hours of rehab a week for 14 months. I'm grateful for my mind, my voice, and the dedicated rehabilitative teams restoring lives. I had a phenomenal rehabilitative team at NYU that took me through my rehab. I'm honored to present to represent the voiceless, and humbled by the medical community's commitment to trust. So thank you so much for your time and attention. I thank the faculty that are part of our program who lift me up every day, and here for questions. Thank you so much.
Thank you very much, Jessica, to share your big experience with us. Are there some questions from the audience?
It's okay if there's no questions.
Do we have some from?
There are some questions from Slido. There's one question from the video. So can you maybe just say what exactly is stretched and broken in the axon during a concussion?
Yeah, we used to think of it as like a snap, but we're finding that it's more of like a stretch and a shear. So if you kind of stretch a rubber band, or you have like that old rubber band that your grandma used to have in the sewing kit with the ball, it just kind of loses its elasticity and therefore its ability to transmit that electrical signal. So we see that things just simply get slowed down through that process. So it's not so much a snap, but more of a shear.
And does it repair itself?
Neuroplasticity is a real thing, but we don't really know to what extent, and you don't really know to what degree of damage that there is. But we do know that movement, low-load cardiovascular activity, bathes the hippocampus and creates BDNF, brain-derived neurotrophic factor, and that's like miracle grow for the hippocampus. So we know that low-load cardiovascular exercise does no harm, and it actually does a wonder of good for everything cardiovascular and brain-related.
This leads to another question. Here the question was, if you have patients with concussion, do they train even if they have symptoms, or at which extent?
It's a great question. So for the purpose of the time that we had, yes, we want to train our patients, but we have to be mindful of position. So we do see dysautonomia very frequently now, which is why we do the physiological approach with the Buffalo Concussion treadmill test. And essentially what you're going to find, what was the question again? Hold on. The training. It's the training load. If you're doing like type 2 muscle fiber training, you're going to increase intrathoracic and intracranial pressure, and you're probably going to freak the nervous system out. So we want to make sure that something seemingly benign, like doing squats, like body weight squats, or squats with a light weight, can increase that intrathoracic and intracranial pressure, including going prone. So I see all the time all over the world people putting their patients into like a bird dog position, but they actually physiologically cannot handle the positional change. So we have to make sure we're looking at orthostatics as well, which is a little bit beyond the 20 minutes that we had today.
Okay, so we will finish with one more last question. And the question is, female athletes seem to have different recovery. Are there any gender differences?
Yeah, so at NIH in 2017, we had a lovely conference there. We literally know from like the point of inception that the female brain is different. Female by sex is different than the male brain. We do know from some phenomenal work, I think it was Jacqueline Cassis, actually, Dusty, Dr. Grooms, and Dr. Master, that was just published this year. With equal access to care, which we know in America is a bit of a problem, so if you have a male and female equal care, so access to care, intensity, frequency of training, like equal care medically, athletic trainers and so on and so forth, that females actually recovered the same as males. And that was through a care consortium study. So again, you have to know what you're looking at so you know what you're looking for. So we see all of this kind of delayed or retarded delay in female outcomes. However, did they have equal access to care? So we just want to make sure we, again, know what we're looking at so we know what we're looking for, so therefore we can advocate for that patient the best that we can and serve the community that you're serving.
So thank you for your insight.
Thank you so much, guys. Thank you so much for having me.